Of course. Yeah. I'm not sure how much agreement we'll get, but
We will see.
my dear old friend Joyce Harper, when I put it up on Facebook earlier today, she put in a comment says, "I still don't agree with this after 30 years," and it's like, okay, well, you're never going to agree, are you?
We have to make a consensus. We have
I
for
know, I know.
patient, for the general doctor, for
Yeah, I've
our.
tried to do it many times, Hisham, but I mean, one of the things that I'll address today is that people just want to believe what they want to believe. And it's really, it's very, very frustrating.
Can do something. I hope so.
Hmm.
I'm always optimistic. I always uh, never stop to try.
Yeah, I know, I know. Well, I used to I spent a lot of time, sitting on the fence and trying to see both sides of the argument. But after a while, I think the evidence became overwhelming, and really, the people that don't want to believe it just still don't want to believe it.
We are here to illustrate this evidence.
Hmm. Yeah, absolutely.
So just 1 minute to start, and I hope this talk is being recorded.
Yes, I
So
heard.
we
Yeah, no
agree on
problem.
this, and
Yeah.
it will be in public. So it can be people can visit this talk later on.
Yes, perfect.
Okay. Okay. Thank you. Bismillah ar-Rahman ar-Rahim. Good evening, everybody. Dear colleagues, it's a real honor for us to have Professor Greven from UK, University of Kent, who is going to address a very hot topic about PGT-A and PGT-B. Last month, we have uh, a talk on the same topic about PGT-A, but from one side. Now, Professor Greven is going to address the other side. Why PGT-A should not be banned, what is its value, what is the evidence behind this PGT-A, and what is PGT-B, because we have not addressed it before. So, first of all, I would like to thank Professor Griffin for his patience on us, for his enthusiasm, and moreover, his open heart and open mind. So, we would like to thank him very much for being with us tonight. And this talk will be later on published or streamed open to everyone. So, the floor is yours, Professor Griffin.
Thank you so much, Hisham, and thank you so much for receiving me. Good evening, everyone. And I understand many of you are back from your Eid holidays, and lovely to welcome you back. Um, it was very interesting to hear a little while ago that there was a call on this forum to see it be to see PGTA to be banned. And I thought, well, let me just address that a little. And this comes on the back of some quite recent analyses that we've done based on the national US data. So I'm largely going to talk about that in my PGT-A talk. And then recently in Lisbon at the Koji conference, I was asked to address the issue of PGT-P, which is something I've not really written too much about, but I thought I'd give it a go. And then the second half is one half of a debate in which I suggested that it should at least be considered, at least in some cases. So if we think of the panoply of PGT, We start with PGT-M and PGT-SR. And by and large, these are not very controversial areas. They were when they were first developed, but when it got to the point of saying, well, if a family are carrying a monogenic disorder, rather than having a therapeutic abortion, then perhaps they might want to have PGT, and that is very much mainstream these days. But contrast that, if you will, with PGT-A and PGT-P. So PGT-A is the thing that I'll consider first. PGT-P could be defined as the diagnosis of two or more genes and/or where relative risk, not absolute certainty, of developing a disorder is assessed. So these are the two that we're going to consider, and I'd like to take a look at PGT-A in the first instance. So at this point, I'd like to introduce my friend and colleague Santiago Monet. We have known each other for an awful lot of years, largely working in the same area. We don't always agree on everything, but we agree on many, many things, and we remain friends and brothers in many ways. And what I'm going to describe to you today is a paper that we had out in the journal BMJ Connections, Clinical Genetics and Genomics. I'm the editor-in-chief of this journal. And I should say that we have a call out for papers in non-invasive prenatal diagnosis, and that includes non-invasive pre-implantation diagnosis as well. So if you have anything in that area, please do consider submitting your paper to us. But this is more or less the first paper that we put in this journal, and it was around PGT-A. And as I say, Santi and I have known each other for a very long time, and we really did used to look this young. This is about 30 years ago, maybe a little bit longer now, in Amritsar in India, where we first met and gave a joint presentation. And I will, in Belgium, be giving this presentation that I'm about to give to you here in a slightly shortened format. And I hope to be doing it alongside Santi once again. So this is the breakdown of the PGT-A talk. We're going to talk about contemporary insights into the efficacy of PGT-A through the mining of the SART database. And if you're unfamiliar what SART is, this is the local regulator and gatherer of data in the United States. So let's first of all give us a primer on PGT, on aneuploidy in general. It is the leading cause of developmental delay, sometimes called mental retardation in humans, in that 1 in 700 children are born with Down syndrome, plus some of the other syndromes that we associate with chromosome abnormalities. It's the leading cause of pregnancy loss. We used to say that it was about 50% of all pregnancy loss, but when we started looking at very early pregnancy loss, we found out that it was a lot more. So it's nearer 80% these days. And the most common are trisomy 16, 18, 21, 22, and monosomy X. It's one of the leading causes of obstetric complications, about 5% of stillbirths, intrauterine growth retardation, intrauterine death, high-low birth weights. It can lead to imprinting syndromes for uniparental disomy, Prader-Willi, Angelman syndrome, and it's and probably the leading cause of IVF failure. It is the major reason for the lack of implantation potential with age. So theoretically, you would think that it should be a no-brainer. You want to be not putting in embryos that might lead to any or several of these things. Now, to give you a brief history of how we used to do PGT-A for many, many years, then there was a time when we used to take the oh, sorry, I'm just trying to put my laser pointer on here. There we go. There was a time when we used to do different types of biopsy. Nowadays, we exclusively do trophectoderm biopsy, but we have in the past done blastomere biopsy from the cleavage stage or polar body biopsy preconception. We used to take cells from the biopsy, spat them down onto a slide, and then do FISH, fluorescent in situ hybridization. That was superseded by array CGH. So you can see in this case, we're looking at all the chromosomes. This one has an extra chromosome 2, a missing chromosome 5. That in itself was superseded by next generation sequencing, and this is from the same cells. And although it shows you the same results, extra twos, missing fives, it gives you a much greater dynamic range and allows you to look for chromosome mosaicism as well. And I'm not going to give a talk about carrier mapping this time, but also by the use of SNP chips or SNPs from next generation sequencing, you can look in more detail at the origin of the error. So PGT-A has been practiced for over 30 years, and the hope was it would improve live birth rates and miscarriage rates. The common indications are advanced maternal age, so beyond the age of 35 for mothers, recurrent miscarriage, recurrent implantation failure, and male infertility, all of which can lead to increased chromosome abnormalities. And in terms of advanced maternal age, a woman of 42 years has a nearly 40% chance of miscarriage, a 15% chance of a successful live birth per embryo transfer if she does not undergo PGT-A. And I want to draw your attention to this graph here. This is a non-selection trial from Teagues et al., from Richard Scott's group, and other studies have confirmed it, that suggest that if you have PGT-A, your success rate on getting a biochemical pregnancy is over 80%. But if you do not have PGT-A, then your success rate is something like 40%. Your chances of a clinical pregnancy are 73% with PGT-A, and a third of that, 23% without. And your chances of a live birth are nearly 65% if you with PGT-A and 0% without. Now, I should say this is referring to when you transfer an aneuploid or a euploid embryo. So let me just go over that again. Transfer of a euploid embryo, 82% chance of a positive serum screen, 73% chance of a clinical pregnancy, 65% chance of a live birth. Similarly, if you transfer an aneuploid embryo, so I may have been slightly misleading there. I said with and without PGT-A. What I meant was transfer of an aneuploid embryo, 40% chance of a biochemical pregnancy, 23% chance of a clinical pregnancy, and 0% chance, literally zero, of having a live birth if you transfer an embryo that you know to be aneuploid. So with that 64.7, nearly 65% chance of live birth and an 80% chance of miscarriage, then why would you not transfer a euploid embryo compared to if you have an aneuploid diagnosis with a 0, maybe up to 1% chance of a live birth, and more importantly, or equally as importantly, a 23.5%, so nearly threefold chance of miscarriage. So to put it another way, the literature post 2020 have had 267 uniformly aneuploid diagnoses that were transfer, and only 3 led to a live birth. And in fact, there's some suggestion that they may be misdiagnoses. So if we consider our embryos in which we have taken a biopsy and 5 out of 5 cells have been proved to be euploid, then we'll call that the green embryos. And if we similarly take embryos that we know that 5 out of 5 cells have been established to be aneuploid, so I'm leaving aside the mosaics for now, then there is a 0 chance of live birth, maybe 1%, but no more. So this represents the dilemma of a prospective PGT-A patient. With PGT-A, let's say, for the sake of argument, there are 5 embryos in this cycle. Roughly speaking, and sticking to very round numbers, we might expect that we'll see 4 green embryos and 1 red one. So at 25 years of age, we might say, well, we're of good prognosis, we've got plenty of time to try again. We might not go for PGT-A. Go to the other end, however, with a 40-year-old, we might see something like 4 embryos that are red and only 1 is green. So in that case, why would you not? And then, of course, just for the sake of completeness, maybe a 35-year-old's got 2 red and 3 green. Sorry, a 30-year-old, 2 red and 3 green, and a 35-year-old, 2 green and 3 red. Now, one of the points of PGT-A here is at least you have that power of selection, that power to your elbow to be able to make that choice. Without PGT-A, however, you are stuck in a black box. You have the element of chance, and any of these embryos could be red or green because you just don't know. You're transferring them essentially at random, albeit based on the basis of morphology. So one of the things that Santi did was log into the SART database, and doing that, you can actually filter and take a look at certain outcomes. Now, let's consider how we look at these. So if we looked at non-selection trials or randomized control trials, we know that the outcome is blinded to both patient and practitioner at the time of treatment. But nonetheless, randomized controlled trials and non-selection trials are very expensive. It's very difficult to reach a large numbers needed, particularly if you want to ask the question of younger patients. Now, the SART database has its problems, of course it does, but it provides these large numbers. And in the USA, in 2022 alone, these are the numbers of the total of IVF cases that were reported. There were 82,000, a little more, that had PGT-A and 56,000 that did not. So in other words, about 60% were PGT-A and 40% were not. So these are extremely large numbers. And the SART results provide us with information for live birth rates per embryo transfer, even in younger patients, and for the reduction in miscarriage. And I'm going to go into each of those in a moment. So the question, of course, we want to know is, does PGT-A work and by what measure? And the short answer to this is we need to consider very carefully what it is that we are measuring. Now, most randomized controlled trials turn their attention to cumulative live birth rate. So in other words, will a healthy live birth ensue regardless of the time period? Now, importantly here, this is not something that theoretically PGT-A can improve, nor was it ever designed to do that. Because just think back to that embryo dish for a moment, then if the family just keeps trying with successive embryo transfers and no PGT-A, then eventually you will find that you euploid one if it exists. So really, PGT-A was only ever there to improve live birth rates per treatment cycle. Sorry, per embryo transfer. Because that, I'm going to the bottom of my slide here, is much better with PGT-A than without. I'll show you evidence of that. But between those two extremes is live birth rate per treatment cycle. Now, theoretically, this is similar to cumulative live birth rate, but it includes all embryos in one cycle only. And the only way that this might be seen to improve by the use of PGT-A is if you put a timescale on the counting. What I mean by that is if you define success that you've become pregnant within 6 or 12 months, then some studies, including one from my lab, have suggested that that might improve per treatment cycle. If, however, you look at the whole of the cycle, it's unlikely to, and an unlimited amount of time, it's unlikely to. It might show an improvement if a significant people will give up, but that's really not a given. But in some countries and in some clinics, there's a 40% drop-off rate after one failed cycle. So it may or it may not. So let's take a look then at live birth rate per embryo transfer and take a look at this graph. So the blue line is with PGT-A, and you can see that the live birth rate per embryo transfer is about 57% there, 57.2%, and only going down marginally. If we consider it without PGT-A, then it's very, very similar. In fact, a little bit lower, even in the younger patients without PGT-A than the older patients with it. And it plummets dramatically if you don't have PGT-A. The blue line is with, the orange line is without. So, in a nutshell, is PGTA effective in improving live birth rate? For cumulative live birth rate, if you just keep trying and keep trying, then no, it is not. And it was never designed to be. For live birth rate per treatment cycle, the answer is maybe, and it depends on how you do the counting. But for live birth rate per embryo transfer, then yes, it definitely is. Which then leads us on to implantation rates. So again, the implantation rate decreases only minimally with advanced maternal age if PGT-A is used. You can see it's very, very similar to the live birth rates I showed you a moment ago. Again, if we consider what the number is for younger patients not using it, it's very similar to older patients using it. And again, it plummets. If you do not use PGT-A, then your implantation rates plummet. Pregnancy loss. Undoubtedly, PGT-A reduces the chance of pregnancy loss. With PGT-A, the miscarriage rate rises only marginally. So from 11.5 to 14.8% with age. Without PGT-A, however, it more than trebles. And again, you see this pattern of a very similar number with a younger patient not using it compared to an older patient using it. And in this case, it more than trebles. So in younger patients, there is still evidence of a significant benefit of PGT-A. So that's the end of the blue line compared to the end of the orange line. And the difference is small but significant. And this goes back to what I was saying a moment ago about a randomized trial would never have enough funding and to produce the numbers to see this difference. But nonetheless, if you combine the evidence of all the randomized trials that's been seen, this is a similar effect of magnitude that we see there. Now, I don't often put comments from LinkedIn into my talks, but this is my friend and colleague Tony Gordon, who I'll be seeing at the PGS meeting in a little while. And I don't expect you to go through all of this. It repeats some of the things that we've said here, but essentially it gives a few highlights. The one that I've just shown you, the difference in rates for younger and older patients. The question there that he asked that we didn't really ask in the paper, but was relatively unique, is how many miscarriages did the USA avoid as a result of implementing PGT-A in 60% of its patients? Because sometimes we look at the numbers from papers without considering those individual impacts. And the answer appears to be that something like 8,500 miscarriages were avoided as a result of PGT-A. And I've literally just added this a moment ago into my slides. So this is an Alessia Snyder, who is a genetic counselor, and I hope that these videos will work. I happen to know, because I tried them literally 2 minutes beforehand, that the audio, for reasons I can't understand, will not work for me, but the video does, and it does have a subtitles beneath it. So I'm just going to let this sink in for you. Miscarriage is extremely significant, and transferring an aneuploid embryo can be catastrophic for them and their reproductive journey. So she thinks the ways of evaluating the success of PGT-A, including cumulative live birth rate, but there is also the patient's experience and their goals. So if their goal is to give every single embryo a chance and they're willing to take the risk of miscarriage, then maybe PGT-A is not for them. Maybe they can just transfer the embryos without having them tested. On the other hand, the patient says, I really want to optimize the chance that I will have a successful pregnancy and minimize the chance of a miscarriage, then PGT-A can be very helpful. And then she goes on to say that, see if I can start this, sorry. Turn that off. If a patient has multiple miscarriages, a reason for those miscarriages that's not because spontaneous chromosome abnormalities. So the reason for the multiple miscarriages may need to be explored separately. That being said, a chromosome abnormality is the number one cause of miscarriage. So there can be multiple things that are happening. PGTA isn't the solution for repetitive miscarriage, but can be something that a patient can control. So they could evaluate if there's a cause of miscarriage that needs to be addressed, but maybe they also want to do PGTA on top. So as long as they're clear, the counselling is clear that PGTA isn't going to be their solution, it's not going to give them their successful pregnancy necessarily, but it can help reduce a cause or an additional cause of miscarriage. It's something that they can control. So she thinks that PGTA can still be offered for repetitive pregnancy loss patients as long as there's really good expectations about what the test can and cannot do. So that's straight from someone who sees PGTA patients every single day, which then allows us to turn our attention to pregnancy rate per egg retrieval. Now, this is an interesting one because it apparently improves pregnancy rate per egg retrieval, but this is somewhat counterintuitive um, because it tends to avoid transfer of abnormal embryos that would not normally lead to live births. So why is it occurring? And it's possibly due to patients with fewer embryos not being recommended to have PGTA in the first place on the basis they've got lower odds of conceiving. So we would argue that implantation, pregnancy rates, and live birth rate per embryo transfer, not per egg retrieval, in fact, are better measures to assess PGTA efficacy. So I've got a few points, miscellaneous points here. Some people say PGTA is experimental. It is not. It is the standard of care in most IVF treatments in the US. And in some countries, particularly in some countries around your part of the world, some clinics do it for 100% of cases. The proportion varies from country to country, so it's relatively low in the UK in comparison. I am not saying it's a cure-all because there is no room for complacency. It is not 100% accurate. Some say it's a 0 to 4% misdiagnosis rate. I think that's a little high. I think the better labs are not anything like that rate. And we know that results could be improved further. So we know that we can improve biopsy because if you have a poor biopsy, then it can lead to poor genetic results, embryonic arrest. And the results can be affected by the cells from the mother. Um, we need to take a look at mosaicism in a bit more detail. I've not got into this in any detail here. It's dealt with elsewhere in the literature. But where it appears in the biopsy, we know that live births can still ensue. And as a general rule, the greater proportion of abnormal cells, the less the chances of live birth. The biopsies that harbour predominantly euploid cells in mosaic embryos, there's very little difference in live birth rate compared to those biopsies where no aneuploidy is found at all, and that needs to be taken into account. Now, SART does not recommend PGTA for all patients. It says the routine use of in all infertile patients cannot be recommended. They still are considering the RCT evidence and they favour intent to treat studies despite their own the results from their own data, which is interesting. Now, intent to treat means that before a couple starts the process of IVF, they decide whether to undergo PGTA or not. Now, obviously, PGTA is a selection tool, and if there's nothing to select because there's not enough embryos produced, that cycle will not show an improvement. Some patients will not, of course, generate enough embryos, and thus perhaps they should not be treated by PGTA. So they would not be included in the PGTA arm, but they would still be included in the non-PGTA arm, which is interesting in an RCT. So there is one argument. So this is one argument for why SART doesn't recommend PGTA for all patients, despite the evidence of its own database. The bias, however, that I was just talked about in this part cannot affect miscarriage rates since both of those groups there's already been an embryo transfer. And importantly, the SART data presented here and a combination of all RCTs show significant reduction in miscarriage rates, even in younger patients. So in conclusion, for the PGT-A part of the talk, PGT-A is a selection tool. It is not designed to improve cumulative live birth rates. It prevented something like 8.5 miscarriages in 1 year in one country. It works for all patients, theoretically, except for those that don't produce enough blastocysts. However, even if you had a single blastocyst, and Semra Karaman addressed this in a paper that she produced, it might be argued that with your single blastocyst, you might want to know whether it's got a 1% chance or a 65% chance of live birth. And that might be money well spent. And of course, we need to consider the cost benefit. The average IVS cycle in the USA is $20,000, and the average additional PGTA is 2,500. And of course, each time you have an embryo transfer, that accrues a cost. So the balance in terms purely of money of the number of the amount of PGTAs versus the amount of embryo transfers needs to be taken into account. And the patient really needs to know a number of things. And the first thing that they will ask is, will I get pregnant eventually? And that is, of course, our cumulative live birth rate or our live birth rate per cycle. They will ask, will this transfer lead to a live birth? That is live birth rate per embryo transfer. Will I suffer pregnancy loss? That's your miscarriage rate. How soon will I get pregnant? That is your time to first pregnancy. And how much will it cost? This varies per clinic and what sort of package they offer, and how satisfying was that experience. So in terms of whether PGT-A helps, cumulative live birth rate, no, it does not, and there's evidence to that effect. So if cumulative live birth rate is the highest point of concern, then PGT-A is not for that couple. Live birth rate per cycle is a subject of some debate, as I mentioned a moment ago, but the live birth rate per embryo transfer and the miscarriage rate, yes, absolutely, and definitely PGT-A does help, as it does to get patients pregnant quicker. In terms of cost of satisfaction, then the cost of extra embryo transfers exceeds the cost of PGT-A, and taking into account all of the above, the degree of satisfaction can be measured to some degree. So it was nice to hear some of the feedback that we received on LinkedIn. And from myself and Santi, thank you very much for listening to the first half of the talk. I want to now, however, revisit PGT-P, the diagnosis of two or more genes. So PGT-M is monogenic, so by definition, you're only looking at one gene. PGT-P is more than one, and where the relative risk, not the absolute certainty of developing a disorder, is assessed. And the question that I want to ask is, should we consider PGT-P? So not should we definitely do it, should we just think about considering it? Because with a polygenic disease, there's a partial genetic component. It might be complex, and there might be environmental factors such as diet, radiation exposure, smoking, exercise, and so on. Monogenic congenital disorders account for about 3% of live births. So it's still not that many in the great scheme of things. Whereas the diseases most worry globally are polygenic, cancer, schizophrenia, diabetes, heart disease, and we all carry a risk. So for instance, our risk of contracting cancer is 50%. So the question needs to be asked, should we use PGT-P to screen embryos in the cases where the odds are significantly skewed and these high-risk families? Which begs the question, is there such a risk such a thing as a high-risk family? And the first thing to say is that the answer is yes. Because if you ask the question of what is the top 3%, that is a distinct group from 40, 60% risk, say, and there's also a sort of 3% protected, so a low risk group as well. So this 3% figure seems to come up quite commonly, and you can see that this red line is quite prominent compared to the other ones. So most people would suggest that at least there is such a thing as a high risk family. And the next thing that people ask is the genotyping accurate? Does what you see in the embryo reflect what you ultimately see in the person? And the suggestion has been that yes, it is, to the point of about 99.7%. So there are some exceptions, but they're rare. So in this part of the talk, I'm not debating whether it should be allowed, PGT-P. I'm not debating whether it should go ahead unregulated. I'm not even saying let's go ahead and perform the first case. I'm only debating whether we should consider it. In many ways, PGT-P is already with us. So we do PGT for digenic syndromes. So remember, PGT can start with more than one gene, so just two. So retinitis pigmentosa, Bardet-Biedl syndrome, deafness, and Hirschsprung disease are all digenic syndromes, and we use those for PGT already. We use it for cancer predisposition syndromes, things like APC mutations or BRCA1 and BRCA2. Now, this doesn't mean that you definitely get cancer. It just means that you've got a significantly raised chance if you've got certain mutant alleles. And we also use it for savior siblings, where we look at the disease plus the HLA type. So in some ways, PGT-P has come through the door already, and we do need to bear that in mind. For the purposes of this presentation, however, I'll use the following definition, and that is detection of variants in 3 or more genes for a single condition where a degree of polygenic risk score information is used. What's the polygenic risk score? Well, for these purposes, it's a percentage risk that an embryo would develop into a person with a specific polygenic disease based on current evidence. And the way that we have established polygenic risk scores is by genome-wide association studies. They're already being used in adult populations to advise things like lifestyle choices, effects of certain medicines, and so on. But of course, the question we're asking here is, should they be used on embryos? And some people say there are a lot of risks involved. There's the question of the slippery slope. Well, hold that thought for a moment, because I'm going to do that in the next slide. They say, well, perhaps it's only something available for the rich, sorry. That applies to an awful lot of diseases and medicine anyway. An interesting thing here is it would encourage complacency potentially. If you were diagnosed as having a low risk for cancer, would you just eat badly and smoke too much, for instance? And then there is a question of how we select the families. I addressed that a moment ago, sliding scale for high risk groups. What about if you had an incidental finding? What about if you found something that you think might be associated with the disease, but you're not essentially sure? If we introduced it right away for everything, there would be inevitably a public backlash. What about those poor genetic counselors who've got to try to explain to patients all of this information? How do patients process this? And of course, times change. What is a high-risk genotype now might not be in 40 years because the environment changes. Now, those of you who follow rugby union might recognize this character. This is Jonah Lomu, possibly the most famous rugby player that's ever been. He's of Tongan background, and in the Tongan population, they are big and strong people. And by and large, they stayed fit, big and strong because there wasn't huge amounts of food around. When times of plenty came along, then the Tongan people, they were big and strong and they were eating a lot more. And obesity is now a huge problem, and death from it is a huge problem. And poor old Jonah, when he stopped playing rugby and started living a normal life, sadly, he died from such disorders. So the question that we need to ask ourselves is, have we really established risk? Because follow-up could take decades and we just don't really know. Some people, of course, would contract the disease for which they were diagnosed as a low risk. So people don't understand risk. Nobody does, and nobody really takes it in many ways. But are all of these reasons why we should not consider PGTA, particularly in selected regulated cases? So I said I'd come back to that idea of a slippery slope, and that's what this is. So at the top, we have our diallelic syndromes, our cancer predisposition syndromes, and our savior siblings already with us for PGT. And at the bottom of our slippery slope here, I've basically included everything in PGT-P. Routine screening, multiple traits, including cosmetic ones. And everything else is an increased increment towards from one to the other. So what about those cases when we have monogenic disorders, but they have low penetrance or variable expressivity? And maybe if you screened a few more genes, you might get yourselves a greater diagnostic accuracy. For BRCA1 and BRCA2, then it's been suggested that really we should be doing this and doing this right now because you get a greater diagnostic accuracy of the risk of cancer. Are high-risk families, such I showed you those red, green, blue, and graphs a moment ago, high-risk families for specific polygenic disease, so maybe those should be on the list. Or maybe as a tool to prioritize the transfer of embryos that you are remaining. So once you've removed the discussion of aneuploid embryos, anything that might have a monogenic disease, then you might think about some others and incorporating an element of polygenic risk score because why not? You could go a step further and say, look, we'll do a general screen for polygenic diseases of most concern. Um, you could say you'll do a more widespread routine whole genome sequencing with as much information about disease risk. And then finally, on your slippery slope, a routine screening for multiple traits, including your cosmetic ones. Now, I would suggest let's just not consider at the moment these last three. The first one is already with us, and just focus our attention here. Because if we just say, look, come on, let's just not even go there with this bottom three. The top one is with us. Focus our attention on these three, make all our discussions about those. Then we are considering sensibly and responsibly. So a PGT report might look something like this. 46XS, chromosomally normal, female, and maybe some absolute and relative risk for some of these diseases that we're interested in, like diabetes, breast cancer, or schizophrenia. So you might say there are lots of positives in favor of PGT-P. You're going to rank the embryo as embryo and anyway, so why not include an element of polygenic risk score? For those variable expressivity and not 100% penetrance, perhaps it's not such a big step. I mentioned BRCA1 and BRCA2. You could, if you practice it widely, potentially reduce the risk of common polygenic multifactorial diseases. Every time someone has a disease like cancer or heart disease or schizophrenia, they're a burden on your health system. So if you can prevent that beforehand, some people say, then you'll be able to divert your resources elsewhere. There is a problem that there are different ethnicities, different populations that the polygenic risk score might not apply to, but those, it has been suggested, are being addressed. Type 1 diabetes, that is a very, very interesting case because in point of fact, I think that I've got this in a couple of next slides. Point of fact, people who undergo IVF, who are carriers or at high risk of transmitting diabetes type 1, have a lower risk have a lower chance of IVF success. So some people say that PGT-P under strict regulation, case by case basis, should be no different to innovations that were previously found unacceptable. IVF, when it was first developed in 1978, I can just about remember it, was hugely controversial. PGT-M was hugely controversial. There were whole debates in our parliament about it. Cloning, stem cells, chimeras, savior siblings, all of them now that are considered mainstream were not at one given time. So maybe some of those things in those three areas that I mentioned really should be considered. Um, because the proponents of PGT-P say you can reduce relative risk of things like breast, prostate cancer, coronary heart disease, heart attack, type 1, type 2 diabetes. They say that they're addressing the confounding effect of different populations and ethnicities. And when we get to this issue of type 1 diabetes, it seems to be associated with assisted reproduction outcomes. So, with and without assisted reproduction, um, it seems to be that there is an association there. In other words, more than 1 in 100 IVF couples are affected with type 1 diabetes. Children of effective parents have got 3 to 20 times the risk, and the polygenic scores claim to be highly predictive. So there's a claim of a 45 to 72% risk reduction with PGT-P. So some people say that it's unethical not to inform patients with type 1 diabetes about at least the option for PGT-P. Now, I'd like to just draw your attention to I mentioned Tony Gordon a moment ago. Here he is again. This is him driving me around Brands Hatch, not far from here, in his Lotus. And we entitled this Pre-implantation Testing for Polygenic Disease, Brave New World on Mad Pursuit, because we address the question here of how pointless or worthwhile is it? Because when we've got in in a PGT-P case, a number of things. Then we've got the question of how pointless or worthwhile is it? Because if we've eliminated the aneuploids and the grossly abnormal ones, how many are left to look at PRS? And how different will be each embryo from the next? And potentially we get into a mad pursuit where we're in a situation where we're agonizing over a polygenic risk score, say for type 1 diabetes, of 55 versus 50%, when in reality we have no idea whether that person is going to get type 1 diabetes or heart disease or cancer, what might be 60 years from now when medicine will be in a very, very different stages and in a very, very different state. So should we really be not thinking about these compared to subtle differences in morphological characteristics? So there is a lot to think about with PGT-P. I wouldn't say I'm a huge fan, but one of the things I think that we should really be doing is seriously considering it now because we it's upon us. Some of the things are already with us and used. A lot of them are there, and it would be really, really sad to ignore it. So, as I said to you, we're not debating whether it should be allowed, go ahead and regulated, perform the first case. I think we should just consider it strictly regulated on a case by case basis. So the answer to that question is an unequivocal yes, because not to consider is just willful ignorance. So to conclude now, we revisited PGT-A. PGT-A is a selection tool not designed to improve cumulative live birth rate. Is that if that is the primary concern of your patients, then it is not for them. If, however, they are concerned by live birth rate per treatment cycle, miscarriage rate, and implantation rate, then yes, it is something that they could seriously consider. So this idea that it should be banned is completely ludicrous. If for no other reason that in the USA it prevented 8,500 miscarriages. It does work for all patients except for those that don't produce enough blastocysts. So if there's one or two blastocysts, then it doesn't necessarily work, but it nonetheless might be of benefit they might want to know. And particularly in younger patients, the cost benefit analysis needs to be seriously considered. In terms of revisiting PGT-P, there are both risks and benefits. And for serious consideration needs to be the monogenic disorders of low penetrance and variable expressivity, particularly those dominant disorders, selected high-risk families for polygenic disease, and possibly as a tool to prioritize the transfer aneuploid embryos. But I would argue no more than that, because we need to consider just how pointless, how worthwhile this is, and what mad pursuit that might be if we don't. And on that note, I will end. Thank you so much for listening to me. It's been a delight to be speaking in Cairo once again, albeit virtually this time. I very much enjoyed being there a little while ago, and I hope to be revisiting you sometime soon. Thank you very much, Cairo.
Thank you very much for this very informative talk, very clear talk, very informative. And I trust we have many, many questions. I will start with my first question myself. Um, how to explain the discrepancy in utilization of PGT-A between country like US and country like UK? In
Yeah, no,
US, it's almost 80% or 60%, as you mentioned, but in UK, it is less than 10%.
yeah, no, that is very much down to the Human Fertilization and Embryology Authority. I've spoken to them many times about this. I have tried to get myself, most recently, on the committee that considers this and other things like IVF add-ons. Um, in another talk, I go into this in a little bit more detail, but essentially what they did was produce a set of traffic lights for IVF add-ons, and I criticized this quite widely, not least of which was these traffic lights had no green in them. So they had red traffic lights to say don't do it. They had orange traffic lights to say be cautious, but not one single IVF innovation was given a green light. And in point of fact, it wasn't even there was no provision for green lights. And I think it impeded the development of PGT-A in this case. I'm a big supporter of the HFEA normally, but I think it impeded it considerably in this case because it was measuring something that could never be improved by PGT-A. So it would only consider the outputs of randomized control trials with intent to treat that were measuring live birth rates, cumulative live birth rates, and were they effective in all patients? So it would only ever get a red light in that sense. So it has changed a little bit and it's softening a little bit, but it's not there yet because you can't really just say we will only recommend it if it's effective for all IVF patients. I think you have to be more subtle than that. So the argument goes on, but essentially the regulator um, regulated it almost out of existence. It is slowly changing. It is increasing, but there are some very loud voices, and we heard them a couple of weeks ago about people who think it should be banned. And I've got I really just presented the results of one study here, but I've got a whole talk on it, on that issue only, and it's a very complex one. The truth is that an awful lot of people have made their careers of either promoting or trashing PGTA, and it's very hard to get them to change their minds either way.
Okay, my second question. You mentioned that it will reduce the time to pregnancy,
Yes.
but clinical studies and published papers showed that this time of reduction is only 3 months. The average is 3 months. So 3 months duration is a very small, a tiny duration. Don't you agree?
It depends who you are. It's highly significant for some patients, less for others. So yeah, I mean, I agree with you that it's perhaps not the first thing on people's minds, but it's still a that average of 3 months is 2 years for some people, and 3 weeks for others. So the ones for which it's 2 years, it's highly significant.
Okay. My second question, the importance of reduction of miscarriage.
Yes.
Is it mainly for those with recurrent miscarriage, or it is just for IVF cases? Do you
Yeah.
mean?
I think it's both. So it's for anyone who has a concern about miscarriage, and many people do. So the more, I mean, I'm not sure that recurrent miscarriage has a very clear clinical definition anyway. So the more miscarriages you have had, or perhaps other family members or friends have had, the more you're concerned about it. So I would say it's more a case of your increasing concern about miscarriage than necessarily a very sort of prosaic definition of whatever recurrent means.
Okay, my most important question to you: are you advocating routine PGT-A for IVF cases?
No, I don't think it's for everyone. And I know some clinics, I know some clinics not far from you, that perform it for everyone. I could see why some people do. And certainly, if someone has unlimited resources, the question is why not? It's a safe procedure. But I would say for some people, it's not necessarily recommended because they would be spending their money without purpose, unless it gives them peace of mind. So I don't think it's for everyone, but I know some clinics do it.
Okay. I may ask a silly question or a tough question. Uh, Professor Abulghar, in his argument,
Hmm.
he said that the PGTA is industry-driven policy. So, do you consider the impact or influence of industry advertisement or push for this PGTA? Because this was one of the main argument with him.
Yeah, I think anyone who's not involved in an industry will often make that case. Essentially, everyone who is paid a salary works in an industry of some description, and whether that be a public organization or a private one, then it still has a budget. It still has to make more money than it pays its staff. So I think in this day and age, it's a very false argument. If it were not for the industries, then we wouldn't have medicine at all. So drug companies are huge industries, and what would you rather do? Not have medicine in that case. So I have to say I really don't like that argument. I think it's very facile. Of course, it's driven by industry. How else would it be? How else would it be otherwise? Because if it were not for industry, you wouldn't have medicine.
Okay. Recently, the state of Abu Dhabi in United Emirates has documented PGTA as a routine for every case.
Yeah, yeah.
Be better to apply PGT-B than PGTA.
I've been having some discussion actually in Abu Dhabi about this, and as far as I understand it, they're not ready for it yet. Um, and one of the problems is what sort of PGT-P do you want to do? So if you were to sequence the whole of the embryo, then you run into this problem of incidental findings. So what if you find something that you really don't know the 100% chance of the of the diagnosis of it? So if someone has two mutant alleles for cystic fibrosis, you know that they're going to get cystic fibrosis. If you sequence the whole genome, there's going to be a whole lot of information that are really gonna have you scratching your head. So what do you do? Then do you sort of say, well, we will do PGT-P for the top five killers in the state of Abu Dhabi, or the top 10, or the top 20, and so on. So I think there are lots of debates to be had. I've not really come down personally with an opinion on this, just to say that we really should be considering it. And I think that, we need to have that discussion and not just sort of ban it outright.
Thank you very much for your time, for your knowledge, and for your open heart and open mind. Actually, this was an amazing talk and amazing discussion. So thank you very much for your time,
Any
and
more
hope to see
questions,
you
Stephen?
in Cairo or in Saudi Arabia.
Yes, absolutely. Does anyone else have any questions? Do we know?
Any questions from the audience? they keep sending me to on WhatsApp so I can give you the questions. Yes.
Right,
Uh,
right. Yeah. So the ones you're reading out with the WhatsApp and the
yeah,
um
yeah.
anything on the chat by any chance, just before we go?
Um, no, no,
No,
nothing.
nothing. No, no worries. Okay, excellent.
And
Well,
it's our time now. It's 1 hour, so
excellent.
we have
Thank you so much.
to leave and say good night to everyone.
Okay, thank you very much, everyone, and thank you for your time. And thank you, Hisham. It's been lovely seeing you again. Cheers then.